Good morning, good afternoon, good evening, wherever you are in the world. My name is Marlies Ostermann, and I'm a professor of intensive care medicine in London. It's a great honor to contribute to this series and to talk about kidney dysfunction and sepsis. These are my disclosures. They've not influenced this presentation. Kidney dysfunction is very common in patients with sepsis. In fact, more than 50% of patients with septic shock experience kidney dysfunction. Sepsis-associated acute kidney injury is the most common form of severe acute kidney injury worldwide. It has a serious prognosis, and patients who need renal replacement therapy have a mortality risk that exceeds 50%. Undoubtedly, our understanding of kidney dysfunction and sepsis has improved a lot, but it remains limited, and there are still some very important gaps in our knowledge. Sepsis is characterized by both pro- and anti-inflammatory processes. Many different cells play a role, and these cells contribute to organ dysfunction in many ways, including the release of inflammatory mediators and cytokines. These processes can occur simultaneously and sequentially. And overall, sepsis is a very heterogeneous disorder. The same applies to kidney dysfunction. It's heterogeneous and very variable between different patients. Some patients develop kidney dysfunction very early, and others only develop kidney function days after the onset of sepsis. Similarly, renal recovery can be very heterogeneous. Some patients regain baseline kidney function within a short period. Others take longer, and some patients never recover baseline kidney function and remain dialysis dependent. There was also a group of patients with recurrent episodes of acute kidney injury during an episode of sepsis. It should come as no surprise that the kidneys are so vulnerable in sepsis. Sepsis is an endothelial disorder, and obviously the kidneys consist predominantly of blood vessels, tubular structures, and interstitial tissues. Kidneys are very vascular organs. Functionally, we can distinguish between the glomerular blood vessels, responsible for glomerular filtration, and the medullary microcirculation, a network that supports tubular cells and also helps with the reabsorption of salt and water. Sepsis is an endothelial disease, and the typical changes are endothelial cell swelling, increased permeability, and impaired microcirculatory flow. And these are the typical features which can lead to organ dysfunction, including kidney dysfunction. And these are the changes that can affect the microcirculatory network within the kidneys. And clearly, endothelial cell swelling combined with micro and immune thrombi contribute to impaired microcirculatory flow and impaired support of the tubular cells. Apart from the microthrombi and the endothelial changes, there's also evidence that sepsis leads to changes in vascular tone. And that's important for glomerular filtration. Normally, glomerular filtration is tightly regulated by the pressure gradient between the afferent and the efferent branch of the renal artery. But these hemodynamics and the pressures may be changed and altered in sepsis. And a degree of vasodilation of the efferent branch can directly contribute and impact glomerular filtration. And in fact, glomerular filtration may decrease or cease altogether. This is made worse by the fact that pre-existing shunts open, and as a result, these shunts completely bypass glomeruli. We've known about this for more than 50 years. And as an example, you have an electron microscopy picture from more than 50 years ago, demonstrating these shunts that bypass glomeruli. And the end result is obvious. Glomerular filtration may stop completely. The tubular cells are also at high risk of being damaged in sepsis, and there are many reasons. Firstly, the tubular cells are always at the receiving end of the glomerular filtrate. And in sepsis, the glomerular filtrate may contain inflammatory mediators, toxic waste products, and substances that directly bind to tubular cells. For instance, damage-associated molecular patterns and pathogen-associated molecular patterns, so DAMPs and PAMPs. This, together with the microcirculatory disturbance, put the tubular cells at very high risk of being injured and damaged. And with regards to kidney dysfunction, I already mentioned the contribution from changes in the hemodynamics and the opening of pre-existing shunts. It also needs to be recognized that the kidneys obviously are highly perfused, and with that, they are at the receiving end of various systemic inflammatory cells. Some of these cells can directly activate cells within the kidneys, and these newly activated cells can then release inflammatory mediators and essentially contribute to the inflammation. These inflamed cells and inflammatory mediators may also be released into the systemic circulation and contribute to remote organ dysfunction. Mitochondrial dysfunction is an important contributor to kidney dysfunction. The tubular cells are obviously among the highest active cells in the body, metabolically very active, and rely on functioning mitochondria. Normally, there's a tightly regulated relationship between fused mitochondria and fragmented, split mitochondria. In conditions of cell stress, this shift may be towards fission and splitting. And this is relevant, particularly relevant for tubular cells. And as a result, ATP production may reduce or cease, and tubular cells may actually become chronically dysfunctional or even become apoptotic. As a result of mitochondrial dysfunction, energy production and energy use is altered within the kidneys, and various metabolic pathways are inhibited and changed. All of this leads to a decreased ATP production. In stress, tubular cells try to protect themselves, and they do this by reprioritizing energy processes, down-regulating ATP-consuming processes, and also inducing a form of tubular cell cycle arrest. The tubular cells may not be functional during this time, but they're at the same time protected from additional damage. So sepsis has multiple ways of damaging kidney function and causing glomerular and tubular dysfunction. This is often associated with additional risk factors, for instance, exposure to nephrotoxic drugs, hemodynamic disturbances, and impaired cardiac function, and also some rarer etiological factors like intratubular obstruction from different drugs. Fluid overload and high right-sided pressures may also cause either acute kidney injury or contribute to the development of acute kidney injury. And clearly, the impact of these different factors is much higher in patients with reduced renal reserve. That's why patients with CKD are at highest risk. Lastly, it needs to be remembered that clinical practice of sepsis may also contribute to the development of kidney dysfunction. So processes of care, for instance, so the use or non-use of different fluids, the choice of antibiotics, and the general management may impact the risk of tubular injury and the prognosis of tubular injury and kidney dysfunction. With regards to management, I'm afraid at present we have no specific therapy for kidney dysfunction in sepsis. So the management depends on the stage of sepsis and the phase of sepsis, and the optimal management of the underlying sepsis. But there's no specific strategy to prevent or manage kidney dysfunction in sepsis. Obviously, we're hoping that some of these drugs that are currently under investigation will be successful. And as shown here, knowledge of the underlying pathophysiology of kidney dysfunction can identify targets for potential future intervention. At the moment, this is all still within the in the research arena, but hopefully some of these new drugs will be successful at either preventing or managing kidney dysfunction in sepsis. So in conclusion, kidney dysfunction in sepsis is very common and has multiple underlying pathophysiological processes, from altered microcirculation to endothelial disease and the activation of inflammatory cells. But there are also factors that are not directly related to sepsis that may contribute to kidney dysfunction, including right-sided heart failure, choice of fluids, and choice of additional other drugs. Insight into the pathophysiology has helped us identifying particular processes that may be amenable to future targeted intervention. But to date, there is no specific therapy for kidney dysfunction in sepsis. Thank you for your attention.